Almost all the preceding speakers have actually answered this question. The Commission's important to try and work out what quality and safety measures should be undertaken in Australia. And so why the heck has that got anything to do with activity-based funding? But Mark and the preceding two speakers clearly answered that, in that funding that doesn't take into account quality and safety clearly is just funding a process without any understanding of whether that process is a good one or a bad one. So the Commission is an Australian government agency, but interestingly we're jointly funded by the Commonwealth and each of the states. So each of the states is a shareholder of ours. We have the remit to lead and coordinate national improvements in safety and quality, and we aim to ensure that the health system is better informed, supported and organised to deliver safe and high quality care. And I guess our remit is to look at patients, consumers, clinicians, managers, policymakers and healthcare organisations, probably in the opposite direction to what most of the other agencies dealing with health are. We want to start with patients and move up rather than start with an organisation and move down. And we want to have a safe, high quality health system in the end that's sustainable. Now we all know that the Australian health system generally performs well if you compare it with other OECD countries. We're relatively efficient. We have a small proportion of our GDP spent on health than most other OECD countries. However, at least 2% of Australian hospital separations have a hospital-acquired complication, and if you exclude hospital-acquired diagnoses in determining the patient's ANDRG, you get at least 3.1% of hospital episodes have a CC, a complicating condition, added to their underlying ABF funding because of something that goes wrong in the hospital. So the Australian system at the moment isn't sufficient on its own to support improvements in quality and safety, and so what the Commission's been doing is to try and look at what programs we can institute across the system to improve safety and quality. In Australia, it's estimated somewhere between 10 and 15% of health spending is inefficient due either to poor quality care or care that is minimally clinically effective. And one of the things the Commission's been trying to do is look at variation to see whether looking at variation will highlight those areas where changes can be made. So variation in healthcare drives differences in quality and in cost. There might be overuse with uncertain marginal benefit. There might be overuse of lower value or supply sensitive care, or underuse of effective care. The Commission did some work developing the Australian Atlas of Healthcare Variation, and I just wanted to highlight one thing out of that atlas is colonoscopy. The dark areas are areas where there's more colonoscopies per 100,000 population than the lighter areas. And you'll notice that this on the map of Sydney, eastern Sydney has a very high rate of colonoscopy, and you wouldn't want to actually drive through there. I was lucky this morning because the airport's here. It's in quite a high area of colonoscopy as well, but no one attacked me, so I was very fortunate. So variation like this across the country might mean that areas of regional and rural areas are underserviced for colonoscopy, and some areas where there are lots of providers may be overserviced. We don't know, and we need to work out what the drivers of that variation are. And that's one of the things that the Commission is looking at to try and understand variation. Now, there are a series of national tools, some of which are in place and some of them which aren't in place, to monitor patient safety and quality. So we've got the national standards. Anyone who's worked in a hospital knows about accreditation and the good and the bad of accreditation. At the moment, the Commission's working on a patient experience survey, or two in fact, to understand what patients experience out of their healthcare. We've got SHBOYS, which are outcome measures. We don't yet have anything to look at organisational culture within our health system in Australia. I'm going to talk about hospital-acquired complications in the complication of this talk. Each of the jurisdictions and each of the private health, or the large private health funds, private hospital groups, has incident surveillance, and as Mark mentioned, there is a list of Sentinel events. So a lot of what we need to have a safety culture across our system is in place, but there are some holes. Patient experience needs more work, and organisation culture currently is hardly touched at all. Sentinel events, Mark mentioned Sentinel events in the new system of not being paid. This is the current Sentinel events list. There's some really interesting things there, like intravascular gas embolism resulting in death or neurological damage. That almost never happens, but when it does, it happens in ICU, so I've seen it a little bit. How important are they? These are the 2013-14 Sentinel events occurring in Australia. And as you can see, while there's lots of suicides and a fair few operations where instruments are left inside, other things are fairly low. So ABO incompatibility, there were none. There were 4 gas emboli in 2013-14. So not paying for those is going to make minimal impact on the system, but it will highlight it to clinicians. Looking at outcomes, there's this thing called CHBOIs, which are core hospital-based outcome indicators. They look at outcomes at a hospital level. Perhaps the most important one is the hospital standardised mortality ratio, which looks at the actual mortality versus a risk-adjusted model for mortality. So if that's higher than 100% or higher than 1, you're doing worse than the model suggests. Those are in place and are reported at an individual hospital level, usually not rounded up to whole system levels yet. Patient experience, the Commission is working on this. It's really about the sum of all the interactions a patient has with the healthcare system and their perceptions in a continuum of care. It's really important to bring patients into focus and important in the safety system. And then complications, and the rest of my talk will really be talking about complications. There are 2 large pieces of work around complications that you need to know about. One is the severe adverse maternal morbidity, and lots of these are pretty horrible things that happen associated with pregnancy, such as eclampsia, which is hypertension and fitting during pregnancy. Some of them are preventable, some of them are not preventable, but that list there and is being collected. And the second list is our list of hospital-acquired complications. So I guess stepping back, before the current health care agreement was announced, why we were interested in activity-based funding. We were interested because we think activity-based funding, even in the form it takes now, does drive safety and quality. We know it decreases lengths of stay. We know it drives a more efficient model of care. You only need to look around the hospitals to see day of surgery admissions to understand that it's driven a lot of change within the system. There are efforts to minimise complications of care, but that hasn't been a focus in the past. And we think ABF funding has driven networking of tertiary services, which is a good thing. Now, back a few years ago, when IHPA were consulting the jurisdictions and the public about the national efficient price, their consultation bubbled up the idea that ultimately safety and quality should go into the national efficient price, and I'm pleased to say the agreement that's just been formed will start that process, but I guess it's going to be some years until it's really very well honed. So in 2012, a joint working party was formed of jurisdictions, senior clinicians and consumers and health managers to start to look at hospital-acquired complications. And the hypothesis was that if we took routinely collected hospital data, so coded data, and fed that back to clinicians for peer review and for benchmarking and for personal improvement, that could have an impact on the system. One of the important things about that is that there's a thing called the condition onset flag, and that tells the coders whether the patient arrived at the hospital, say, with malnutrition, or whether they developed malnutrition during their hospital stay. And so it's really important that that condition onset flag is accurate, and so that was one of the questions that our group set out to look at. In the literature, there's really strong evidence that feeding data back to clinicians drives behavioural change. Now, as the director of an ICU, a big ICU, spending multiple millions of dollars, I didn't ever get any administrative data to tell me how I was doing. Didn't even get much data to tell me how much I was spending. All right, so the system needs to actually close the loop. There's lots of good data in the system, but that data needs to be fed back to practicing clinicians. Now, my project officers scrambled this slide, but in fact, those prime ministers straddle this work. And so in 2012, we set up a joint working party. In 2013, we did literature review and environmental scan. A proof of concept started in 2014 and 15, and now in 16, we've had this COAG health heads of agreement. So the first step was to go and look at the literature. In the literature, there's equivocal evidence, not great evidence, that altering price can drive safety and quality. However, what we decided to do was to start to look at the coded data to see whether that inpatient coded data could be used as a screening tool to tell us something about the quality and safety of an institution, and could be used for a quality improvement tool to feed back to clinicians. So we needed a list, and we got a group of senior clinicians together. We took a list through the ANDRG, and KPMG did a study for us that showed that we could identify, that the list identified complications within the coded data sets that we could use to feed back. Now, the group looked for preventability, for patient impact, for severity, for impact on the health service, and for clinical priority, and they came up with 40 complications in 16 groups. They also came up with some things that are important to understand in the system that currently aren't coded. And so the group worked on definitions for unplanned return to operating theatre, for unplanned admission to intensive care, and for rapid response call. And they've been loaded up into Meteor, and we're working our way through seeing whether we can get them added to the national inpatient data set. So these are the current hospital-acquired complication lists. As you can see, they're the sorts of things you would expect. So pressure injuries, falls, healthcare-associated infections. And I guess as a clinician, one of the things that used to concern me was the preventability of these things. So falls, you know, lots of patients fall in hospital. We know why they fall. They fall because they're confused. The bed rails are up. They climb over the bed rails. There's no one in the room with them. They fall. I thought it's largely not preventable. But in fact, South Australia has managed to reduce their falls rate by over 50%. One of my hospitals that I work in did this project called mindful rounding, nursing rounding. And mindful rounding consists of the nurses going around every hour and asking the patients whether they need a drink, like I do, whether they want to go to the toilet, and what have you. And in fact, bizarrely, they found that after they did mindful rounding, the fall rate went skyrocketing. And what it was unfortunately the nurses were cueing the patients to think about going to the toilet. They'd say no, and by the time the nurse was in the next room, the patient would jump out of bed and fall over. But anyway, largely these are preventable. And as you can see, we've got unplanned admission to ICU, unplanned return to surgery in there. And one of my favourites here is delirium, because it's said that 70% of patients in ICU are delirious. And I can put my hand on my heart and say that I never once wrote delirium in any medical note. Okay, I did write encephalopathy, which is actually the same thing, but that's one of the problems, is doctors don't necessarily write the right things in the notes, and we have to train ourselves to do that. So we tested this, 2 phases of study, one in 14-15 and one at the end of last year. We looked at the accuracy of the coding and the completeness of the coding. We recoded 5,000 medical records in 4 public hospitals and 5 private hospitals, and I'm really pleased to say that there's good agreement, especially around the cough, which is extremely high, and most of the other conditions coded, there was agreement between the initial coding and the recoding, so that looks like coding isn't a problem for the system. As I said, probably the problem for the system is doctors that don't write the right thing in. Then we fed the data back to clinicians, and most of the clinical groups we fed it back to thought it was useful. They thought it was useful for their morbidity and mortality meetings. But importantly, they also saw it as useful for understanding what was being written in their notes and fixing that up. So when they had a patient who'd had a pulmonary embolus, didn't come up on the list, they could go and look at why the heck that hadn't happened. So the testing showed the tool was seen as useful by clinicians and found some improvements in the documentation are needed. High consistency across the first and the second coda. The cough flag is good, and the hacks are relevant to safety and quality improvement and can be used for a screening tool at a local level. And you all know, because Mark's just told us about this, heads of agreement. So IHPA and the Commission are developing a proposed joint approach to looking at safety and quality. We're looking at resources to improve medical documentation. Lots of medical documentation, at least in public hospitals, is undertaken by junior doctors. Mostly they've never had any lectures about what's supposed to go in the notes, and so we're looking at how we can fix that up. The IHPA are developing an interactive tool for local monitoring of complications, and we're looking at mechanisms for benchmarking across the system. Now, anyone who's heard me talk before would know that I wouldn't go away without telling a stupid story. And when I told my partner I was going to tell this story, she went ballistic and said I shouldn't. But anyway, here we go. Mainly because I actually had an underworld figure here in the front slide, and she pointed out that the underworld figure I'd chosen was still alive and might come and bop me. So this is a story about a hospital-acquired complication and how I ended up being charged with murder. So one of Sydney's Mr. This is true. One of Sydney's Mr. Biggs was shot through the axillary artery. For those of you who didn't ever do anatomy, the axillary artery is that big red thing, and it's a big blood vessel under your shoulder. So Mr. Big was shot through the axillary artery, nearly died. Plastic surgeons and vascular surgeons spent hours and hours and hours reconstructing it. Came back to the ICU, spent a few days in ICU and got better. And on his way out of the ICU, he was Mr. Big both in reputation and in size. I told the junior doctor, look, I think he's really big. We'd better increase his heparin to prevent a DVT. Why don't you put him on 5,000 units TDS instead of 5,000 units BD? And the junior doctor wrote in the medication note, calciparin, 5,000 units TDS. Anyway, Mr. Big went to the ward. On the ward, about 10 days after the operation, as inevitably happens in the bathroom, he had a cardiac arrest from a big pulmonary embolus and ultimately died. That was the last I heard of Mr. Big, but he'd had a hospital-acquired complication, a DVT and a pulmonary embolus, despite us giving him prophylaxis to stop it happening. So not all complications are preventable. 2 years later, I got a summons to appear here at Darlinghurst Court. And there was a lot of fuss because the detectives actually came and talked to me and wanted to know what I was going to say, and I thought, this is unusual, they don't usually do that. Anyway, I rock up to Darlinghurst Court and I'm asked to give evidence. And the man who'd been accused with shooting Mr. Big had been found, and his barrister asked me, Dr. Herkes, would you look at the medication notes of Mr. Big and tell us why you ceased his heparin when he left the ICU? And I looked at the medication notes and I said, no, in fact, we increased the dose of heparin because calciparin is calcium heparin. And the lawyer, Dr. Herkes, will you look back in the notes to the preceding admission where this man came in with an acute myocardial infarct with a heart attack? And please tell the jury how much heparin the patient was receiving. I looked at the notes and said, well, he was receiving 70,000 units a day. But you only put him on 15,000, Dr. Herkes. And I said, if I'd given him 70,000 units a day, you'd have me here asking me why I let him bleed to death. To which the judge said, very right, stand down. So the message is, a lot of these complications are partly preventable, they're not always preventable, and sometimes you have to balance one potential complication, in this case a DVT and a pulmonary embolus, versus another complication, a bleed from your shot axillary artery. So I guess the message is, in this funding model that we're going to develop to look at safety and quality, we really do need to look very carefully at risk stratification and normalising the data to make the funding model appropriate and work within our system. Thank you.
I'm pretty sure there's questions for Rob. I can just guess it. I'm just wondering how we risk stratify for underworld figures.
Best avoided.
Yeah, okay. Any questions?
Is there any risk of having these funding models associated with healthcare skewing how medicine is practiced to create artificial scenarios? For instance, I noticed prevention or occurrence of hospital-acquired infection was an issue, so that could persuade doctors to utilise more prophylactic treatments and induce drug resistance, which is going to cause more problems in the future.
So I guess I'll answer that in a perverse way. So I'm from ICU, and I was the director of the New South Wales Intensive Care Network. And we thought we ran our ICUs pretty well, and we thought we had a very low rate of central line associated bacteremia. But there were all these initiatives in the States around decreasing central line associated bacteremia and CLABSI and things, and we thought, oh well, we'll give these a go. And so by changing our practice, we took our rate of central line associated bacteremia across New South Wales from about 3.5% down to about 0.2%, and had a very significant change. Even though we thought we were doing well, we were wrong. I think you could develop, we have to be sophisticated about this. Just blanket saying if you have a UTI, that's bad, you're going to, naughty you won't be paid, is not the way this is going to work. And I think clearly we need to look out for adverse and contrary outcomes from implementing some system like this. But I think in the end, reflecting on what some of the previous speakers had said, I think the actual clinical view of the world and the clinical acceptance of change, just like we heard from our American speaker before, has completely changed over the last 5 years. If we published an atlas of clinical variation like we have done that highlighted changes that don't seem easily explicable, 5 years ago there would have been World War III. If a government had initiated some of the reviews that have been initiated, they wouldn't have been accepted by the clinical community, but they are. So I think the world's moving on, and I think genuinely lots of senior clinicians want to get things better rather than just continuing to increase the volume.
Thank you. The thought came to me in the earlier address, but it comes back here. There was been a lot of focus in the past on the medical indemnity system, and we had the crisis in it now 15 years ago. But would you like to comment on the interaction between this process and the medical indemnity system and any related reforms that might be needed there?
So as a clinician, I don't think saying that these hospital-acquired conditions are potentially preventable presents me with any litigation risk. There's potentially preventable. What it does do means that I have to make sure I've got in place appropriate preventative strategies. And I think, the truth is most of our hospitals do have in place strategies, it's just they're not using them universally yet for lots of these things. There's patchy implementation of the strategies. So I think changing the funding model to drive universal healthcare safety and quality will actually be useful, and I don't think it'll imply that individual clinicians are exposing themselves to extra liability. Certainly that's not the intended outcome.
Thank you. My name's Kasha Bale from the University of Canberra. Just wondering if you could perhaps talk to one aspect. A number of those complications that you listed are potentially preventable by nurses and nursing.
Yep.
What's the impact, I suppose, of nursing documentation for coding? And what can you maybe talk to, I guess, those perverse indicators potentially about if you look at falls, those complications can actually be increased by encouraging patients to stay in bed where they're safer. And also because nursing is often used as a cost-cutting measure, perhaps replacing with AINs, which might have an impact in relation to falls and those complications.
Gulp.
Sorry.
I guess one of the things that's come to me as a doctor over the last few years is there's a lot of emphasis on doctors, but in reality we're all teams, okay? And the best surgeon in the world can't do virtually any operation without a good anaesthetist, a good scrub nurse, and a good ward to send the patient back to. So we're actually all teams, and one of the things that I think as a group, and I'm guilty of it, so I apologise, we have to move away from is craft group centricity. You know, what we are a clinical team that are looking after groups of patients, and if any part of our team falls down, then that patient's harmed, and the patient doesn't do as well as they should. Unfortunately, moving from our system at the moment that's doctor-centric to that will take some years, but I think we are moving that way. Even some of my cardiothoracic surgeons, who are, as you would know, one of the most less insightful groups of doctors in the world, are starting to appreciate that they can't just go out to West Wyalong in isolation and do a whole heap of surgery and expect it to go well. So I think the nursing team plays a really important part in looking after patients. As you say, we have to avoid perverse outcomes such as leaving patients in bed or tying them in bed, even worse, so they won't jump out of bed. But there are some really good nursing strategies to improve those things, and I think and writing documentation from nursing. There's been a lot of work in nursing around documentation by exception. All right. I'm not sure that that's all that's the utility of that in the long run. And I think documentation of nursing, particularly around pressure sores and some of those things that doctors never actually seem to see, is really vital to improving safety and quality into this system. So pressure ulcers, especially the grade 3 and 4 pressure ulcers, were actually well coded. So lower grade pressure ulcers, grade 1, as you know, probably is just a red skin. Ultimately, that will probably come out of the HAC list that's used for a model for funding, because having red skin's just what my feet have at the moment from standing here for 10 minutes.
Hi, Rob, Joe Scateri.
Sure.
I noticed with interest the proposition to add some data elements to the admitted patient data set around return to theatre and so on. I just wondered the extent to which the work that you're doing has explored the use of the various clinical registers around the place as a source of outcome data that then might generate quality indicators and somehow be linked to payment.
So one of the things that the Commission and IHPA are doing jointly, which I didn't touch on during this talk, is best practice pricing. We've done a best practice pricing model for fractured neck of femur. As you would appreciate, Joe, one of the most important things about care of fractured neck of femur is timely surgery, so that almost invariably elderly people don't lie around for long periods of time. And then the second thing that's really important is having a psychogeriatric model of care that's just not the orthopaedic surgeon coming in at 6:10 every morning, waving at the patient from the end of the bed and then going off and spending the next 12 hours in theatre. So in the model of best practice pricing we've worked up for fractured neck of femur, there's a registry that collects a lot of the data. And so we're exploring the possibility of using the registry data along with the admitted patient data, linking them to try and prove that the patients are getting best practice care. So registries do provide an important function within our system. They do provide lots of clinicians with direct feedback about their own practice and benchmarking of their practice. And the Commission's in the process of working up a paper that looks at the value proposition of registries.
I I just wanted to make a comment in relation to the coding of these particular conditions that may be documented in the medical record from a nurse rather than a doctor. In the hospital system, it may still be very doctor-centric, but in the coding world, it is provider neutral. So the clinical coder will go through the medical record and look at all documentation to ensure that they pick up on the codes that are required to be coded according to the Australian coding standards. So if pressure ulcer is documented by a nurse rather than a clinician, surely it is verified. They look at the whole medical record, but it is provider neutral and we will code it.
Great, thank you.
I just wanted to, Darryl Wims, I just wanted to follow up on registries and their interactions in outcomes in stroke, unplanned admission and cardiac outcomes. There's a lot of benchmarking that gets done through Health Roundtable, Dr. Foster, a variety of things. And when you look deeply and you compare your administrative data set and outcomes compared to registry outcomes, they are often radically different. And that's because some have tertiary level stroke services with interventional capability that attract the highest risk patients, and those things aren't picked up on administrative data sets. Similarly with major trauma centres and unplanned readmissions to theatre, and also some cardiac outcomes. So I'm just wondering how you will integrate that information.
So I think it's an important question, and networking and stratification of our hospital system. So say a jurisdiction only has several trauma centres rather than everywhere pretending they're capable of doing trauma, or only funds one clot extraction service for stroke rather than everywhere pretending they can do it. That's really important for the evolution of the health system, so that you get specialisation and expertise and clustering and can afford that expertise at a jurisdictional level. But as you're pointing out, making the funding model that's going to take in quality and safety acknowledge the different patient case mix and the different patient flows. And as we all know, if you come from another hospital, that carries an increased burden of disease and an increased risk of mortality. They're the things that risk stratification within a funding model is going to be really important, and they're acknowledged as important issues to be sorted through. So no one thinks every hospital is the same and every hospital should be funded exactly the same.
I'm going to change the topic a bit, if I may. Thanks for the overview. I'm interested in how we are actually going to implement these things, not at the technical level of coding, but thinking about how it's done. So if we think about the point that you made about feedback, particularly to doctors, in the early part of the talk, that's really about working on their intrinsic motivation to do a good job, to do good in terms of the whole system. And I think that's something that Shane highlighted this morning is a very important motivation. But lots of financial incentives and penalties are really at the other end of the spectrum. They're about extrinsic motivation and, carrots and sticks. How are we going to move forward in this agenda for pricing, safety and quality without losing or damaging the intrinsic motivation of people to do a good job?
So I think you've pointed out another really important thing. You have to work out who the target of your penalty or your bonus is. So if what you're wanting to do is change the behaviour of a clinical team, and then clearly if your target is a network of hospitals, it's pretty far off the clinical team. So I think that's will be one of the interesting things for us to work on. I think, however, the hospital administrations and network administrations can look at ensuring they have the supports in place for their clinical teams to undertake appropriate clinical practice. They can make sure they have the policies and procedures in place, say, to make sure everyone has DVT prophylaxis where that's appropriate. And they can have the policy to look at how you balance the risk of a hemorrhage versus a DVT. So I think there's quite a lot that centrally or organisationally can be done to support frontline clinicians. When I say clinicians, I mean doctors, nurses, allied health people, everyone, not just some people think I mean just doctors, but I don't. I mean the whole clinical team. So I think it is an important point. I think we can do things at an organisational level to support the frontline services, and I think that's one of the first things that any prudent administrator would do if they're looking at funding for safety and quality, is making sure that there are safety and quality systems in place to support their staff and to support their patients. It's not an adequate answer because at the moment the model's completely unworked up.
Thank you. Just another perspective. I was wondering with patient experience if you're also incorporating the carer impact and experience. Patients are part of a network of people who support the patient, and yes, the carers and the loved ones of that patient are really crucial to keeping the patient well, and their experience of the system is equally pertinent to understanding how the system's working for that patient and their family or their loved ones. So yes.